Hypertension. Hypertension is a prolonged elevation in blood pressure. Symptoms of hypertension, usually asymptomatic until complications develop in target organs. Severe hypertension can cause severe cardiovascular, neurologic, renal, and retinal symptoms. A fourth heart sound is one of the earliest signs of hypertensive heart disease. Retinal changes may include arteriolar narrowing, hemorrhages, exudates, and in patients with encephalopathy and papilledema. Normal physiology. Blood flows from areas of high pressure to areas of low pressure. Blood flows in the same direction as the decreasing pressure gradient. The rate or velocity of blood flow varies in an opposite manner with the total cross-sectional area of blood vessels. As the total cross-section of the blood vessel increases, the velocity of the flow decreases. When the total cross-section of the blood vessel decreases, the velocity of the flow increases. As the blood vessel diameter decreases, the resistance increases and the blood flow decreases. Very little pressure remains when the blood leaves the capillaries and enters the venules. Blood flow through the veins is not the direct result of ventricular contraction. Instead, venous return depends on skeletal muscle action, respiratory movements, and constriction of smooth muscle and venous walls. BP is regulated by three key variables: cardiac output, total peripheral resistance, and blood volume. Anything that increases cardiac output or total peripheral resistance increases blood pressure. Blood pressure also varies directly with blood volume because cardiac volume depends on blood volume. The heart cannot pump out what does not enter the chamber. The factors can be affected by short-term regulation, neural control. Neural controls operate through reflex arcs that involve the cardiovascular center of the medulla, baroreceptors, chemoreceptors, and higher brain centers. They can change blood distribution, the organs, and blood vessel diameter. Cardiovascular center, clusters of sympathetic neurons in the medulla, consists of cardiac centers, cardioinhibitory and cardioacceleratory center. Vasomotor centers, which sends steady impulses via sympathetic efferents called vasomotor fibers to blood vessels, receives inputs from baroreceptors, chemoreceptors, and higher brain centers. Baroreceptor reflexes, located in carotid sinuses, aortic arch, and walls of large arteries of neck and thorax. If mean arterial pressure is high, increased blood pressure stimulates baroreceptors to increase input to vasomotor center, inhibits vasomotor and cardioacceleratory center, stimulates cardioinhibitory center, results in decreased blood pressure. Short-term regulation, hormone control. Epinephrine and norepinephrine. Increase blood pressure by increasing cardiac output and total peripheral resistance. Angiotensin II increases blood pressure by increasing total peripheral resistance. ADH increases blood pressure by increasing total peripheral resistance and blood volume. Aldosterone decreases blood pressure by decreasing blood volume. ANP decreases blood pressure by decreasing blood volume and total peripheral resistance. Long-term mechanisms, renal regulation. Long-term mechanisms regulate blood pressure by altering blood volume through the kidneys. Kidneys regulate arterial pressure by direct renal mechanism, indirect renal mechanisms. Direct renal mechanisms alter blood volume independently of hormones. Increased BP or blood volume causes more urine. Decreased BP or blood volume causes kidneys to conserve water. Indirect renal mechanisms. Decreased blood pressure causes release of renin. Renin catalyzes conversion of angiotensinogen from liver to angiotensin 1. Angiotensin converting enzyme converts angiotensin 1 to angiotensin 2. Angiotensin 2 stimulates aldosterone secretion, causes ADH release from posterior pituitary, increased water reabsorption, triggers hypothalamic thirst center, and acts as a potent vasoconstrictor. How the disease affects normal physiology. Blood vessels become less elastic and more rigid as patients age, which reduces vasodilation and increases systemic vascular resistance, leading to higher systolic blood pressure. Hypertension in younger patients tends to be associated with increased cardiac output, which can be caused by environmental or genetic factors. In most patients, cardiac output is normal or slightly increased, and total peripheral resistance is increased. In other patients, cardiac output is increased and total peripheral resistance is inappropriately normal for increased levels of cardiac output. Later, total peripheral resistance increases and cardiac output returns to normal because of autoregulation. Some disorders that increase CO, particularly when stroke volume is increased, cause isolated systolic hypertension. Some elderly patients have isolated systolic hypertension with normal or low CO, probably due to inelasticity of the aorta and its major branches. Patients with high fixed diastolic pressures often have decreased CO. Plasma volume tends to decrease as BP increases. Rarely, plasma volume remains normal or increases. Renal blood flow gradually decreases as diastolic BP increases and arteriosclerosis begins. Glomerular filtration rate remains normal until late in the disorder. As a result, the filtration fraction is increased. Coronary, cerebral, and muscle blood flow is maintained unless severe atherosclerosis coexists in these vascular beds. The renin-angiotensin-aldosterone system helps regulate blood volume and therefore blood pressure. Renin, an enzyme found in the juxtaglomerular apparatus, catalyzes conversion of angiotensinogen to angiotensin 1. This inactive product is cleaved by angiotensin-converting enzyme, mainly in the lungs, but also in the kidneys and brain, to angiotensin 2, a potent vasoconstrictor that also stimulates autonomic centers in the brain to increase sympathetic discharge and stimulates release of aldosterone and vasopressin. Aldosterone and vasopressin cause sodium and water retention, elevating blood pressure. Aldosterone also enhances potassium excretion. Low plasma potassium increases vasoconstriction through closure of potassium channels. Angiotensin 3, present in the circulation, stimulates aldosterone release as actively as angiotensin 2, but has much less pressor activity. Because chymus enzymes also convert angiotensin 1 to angiotensin 2, drugs that inhibit ACE do not fully suppress angiotensin 2 production. Angiotensin is generally responsible for renovascular hypertension, at least in the early phase, but the role of renin-angiotensin-aldosterone system in primary hypertension is not established. Hypertension due to chronic renal parenchymal disease results from the combination of a renin-dependent mechanism and a volume-dependent mechanism. In most cases, increased renin activity is not evident in peripheral blood. Hypertension is typically moderate and sensitive to sodium and water balance. Deficiency of vasodilator, bradykinin, or nitric oxide rather than excess of vasoconstrictor, angiotensin, or norepinephrine may cause hypertension. Reduction in nitric oxide due to stiff arteries is linked to salt-sensitive hypertension, and in order to increase of greater than 10 to 20 mmHg systolic BP after a large sodium load. If the kidneys do not produce adequate amounts of vasodilators, blood pressure can increase. Vasodilators and vasoconstrictions, mainly endothelin, are also produced in endothelial cells. Treatments. Lifestyle changes: losing weight if overweight or obese, quitting smoking, eating a healthy diet, reducing amount of sodium in the diet less than 1,500 milligrams a day, getting regular aerobic exercise, limiting alcohol consumption, 2 drinks per day for men and 1 drink per women, stress management. Medication treatment. First-line drugs, diuretics cause fluid loss through urination, excretion of water and electrolytes, decreasing blood volume. Angiotensin-converting enzyme inhibitors help relax arterioles to relax by preventing your body from producing angiotensin 2 to avoid narrowing of blood vessel. Angiotensin 2 receptor blockers block receptors for angiotensin 2 in arteriolar smooth muscle and an adrenal gland, causing blood pressure to fall. They have the effects of arterial dilation and increased sodium excretion by the kidneys. Calcium channel blockers block calcium ions from entering cell and cause smooth muscles and arterioles to relax. Second-line drugs, alpha-2 adrenergic agonists and alpha-1 adrenergic agonists work to lower blood pressure by relaxing the smooth muscle and small arterioles and cause vasodilation. Beta-adrenergic blockers and centrally acting alpha and beta blockers block beta-1 and beta-2 receptors are both in decreased rate and force of contractions in the heart and slow electrical conduction through the atrioventricular node. Direct-acting vasodilators act directly to relax arterial smooth muscle, decreasing cardiac output and oxygen need. Direct renin inhibitors block enzyme renin from triggering a process that helps regulate blood pressure and blood vessels relax and widen. Current research has found that linking blood pressure and cognition. The American Journal of Hypertension has recently found a connection that shows the link between elevated BP and risk for cognitive impairment or dementia. Their study included using data from neuroimaging or autopsy to identify abnormalities in the brain, resulting in atrophy, cerebrovascular disease, cerebral blood flow. An abnormal cerebral blood flow, low blood flow, and higher pulse indicate a risk for cerebral vessel disease, which includes white matter hyperintensities and cerebral microbleeds, resulting in cognitive decline. However, their findings suggested that lowering BP would slow or stop the progression of white matter hypersensitivities.